This conference will now be recorded. This conference will now be recorded.
Okay, so now continuing where we finished off last time, we were talking about the colorectal polyps, and that I told you was an important part, basically because they form an important pre-malignant condition for colorectal cancers. Now, proceeding on to the second part of the topic, and that is the colorectal malignancies. We'll be concentrating more on the colonic malignancies at this point of time. The acknowledgements and purely educative, and the three reference books that I would suggest would be the Schwartz, the Sebastian, and Love and Bailey, and of course Fisher's Textbook of Surgery. Now, coming to colorectal malignancy, just relevant statistics, some important relevant statistics. And the first is that it's third most common cancer in males and females overall. And if you look at the GI cancers, there is the commonest GI cancer in males and females. Synchronous bowel tumors can be found in almost 3%. That basically means that along with a colonic cancer, you can get another GI cancer. So you can have a synchronous bowel tumors. Metachronous CRC, CRC basically is colorectal cancer. We'll just say CRC from now on. Second, primary CRC would be found in 3%. That means you have operated on a patient of CRC, you believe the patient is cured, and then you have either a second primary identifier, or at the same time, when you're doing identifying the first one, you get a second one, second site of CRC. That's found in 3% of cases. Now, 50% of all CRCs will develop liver mets at some time or the other, either at the time of diagnosis for the first time, or if you follow the patients up in the follow-up case. Now, overall, a very important figure to remember is that not all colonic malignancies are familial. Only 75%, roughly 75%, I mean 3/4 of the patients of colonic malignancy would be having sporadic. That basically means it is not carried in the family, nor have they inherited from their forefathers. So it is sporadic, appearing for the first time in the family, while the rest 25 to 30% are either familial or hereditary. Hereditary is about roughly 5 to 6%. You can stretch it up to 10%, and familial is about 20-25% familial. So that means 3/4 are sporadic, and 1/4 would be either familial or hereditary. If you look at the overall 5-year survival rate, I've purposely stuck to Duke's classification because this is a very pragmatic classification and still being followed in a number of places. Proceeding from a very good survival, that gives you an idea what kind of malignancy this has. Because whenever we talk about a GI malignancy, immediately what comes to mind is whether this patient going to survive or not. Like for example, you talk about esophageal malignancy, you talk about a gallbladder malignancy. We know they've got very poor survival figure. 5-year survival rate is very, very poor overall. Not only stage 1 or stage 4. Overall, it's roughly less than 10%, in the region of 3 to 6%. Esophagus, gallbladder, all these. But when you look at the colonic cancer, if you find it in the early stage, which is usually very common, I wouldn't say uncommon, not uncommon, it is almost 90%, more than 90%. That basically tells you that more than 90% of these patients can be cured of the disease. Well, if you go up to stage 4, then you have a survival of less than 10%. Right? So overall survival, look at the overall survival, it's a 50%. It's a very healthy survival as compared to the other GI malignancies. Now let's look at the risk factors for sporadic. Now I've purposely highlighted sporadic for the simple reason that the other group, which is the hereditary familial, has got an obvious genetic defect there. But in sporadic, there may not be an identifiable genetic defect. It may have a genetic defect, it may not have a genetic defect. But what are the features which you would find which would be propagative to the development of malignancy in a patient of CRC? Number one, dietary factors. And what about the dietary factors? If the patient is having 20% fat in his diet, what kind of fat? Polyunsaturated and saturated fatty acids. These are high risk factors. So if you have more than 20% of these polyunsaturated or saturated fatty acids in the diet, then you are at increased susceptibility to the genesis of cancer of the colon. Cholesterol and dihydrocholesterol present in the diet and metabolites are directly carcinogenic. Alterations of the concentration of colonic bile acids, like example, you find in post-cholecystectomy patients. In post-cholecystectomy patients, the incidence of colonic cancer of the right side is higher as compared to the normal population. This is the reason. There is an alteration in the concentration of the colonic bile acids and metabolic activity. but high diet in other fatty acids, like for example, which contain oleic acid, coconut oil, which is a very common used oil for cooking purposes, fish oil, olive oil, they do not increase the risk. So remember, 20% fat, more than 20% fat in a diet, but mainly polyunsaturated and saturated fatty acid. Okay. Now, increased fiber content is protective. Now, this theory is substantiated by a number of facts. Number one, less commonly in the African Negroes and in the Asian population. Why? Because in these two populations, there's an increased amount of bulk in the diet. An increased bulk or bulky diet leads to faster transit, and faster transit itself leads to what? A decrease in the contact time between the stool and the bowel wall. And stool has the carcinogens in it, and the bowel undergoes carcinogenesis. So if you have less time of contact, obviously it will be beneficial for the patient. Less antioxidants are probably protective, which may seem to be a slightly aberration. Why? Because we know that antioxidants are beneficial for the body, but here less antioxidants are probably beneficial as opposed to having a increased content of antioxidants. And that has been shown by latest studies that those antioxidants which have flavonoids and other plant compounds like vitamin C and E would actually raise the risk of bowel cancer. So these are the two sporadic, the dietary risk factors for sporadic cancer. What are the other factors? The other dietary risk factors have to do with number one, beer, asbestos, spices, smoked foods because of nitrites in it, food additives, nitrites again, smoking. There is an increase of 30 to 40 times, 40% increase. Red and white meat, ingestion of calcium, selenium, vitamin C and A, we just now said that in antioxidant as propagative of malignancy. So all these are dietary risk factors which increase the risk of colonic cancer, CRC. What about the age and sex distribution? Now, as soon as your age crosses 50 years, you become increasingly susceptible, and at the age of 75 years, you peak with the incidence of colonic cancer, CRCs. So more than 95% of patients of CRCs are over 50 years. That itself tells you that it is basically a disease of post 50 years age group. Male-female ratio are equal, but colon malignancy is more common in the female population, right? Younger age group patients usually have associated familial disease. So if you have one of these familial or hereditary CRCs, you have probably got a younger age for manifestation. What about inflammatory bowel disease? Remember, we were talking about ulcerative colitis and Crohn's disease. Both of them are pre-malignant conditions in the sense that ulcerative colitis has been there for more than 20 years. You'll be almost at a risk of 5 to 10 times more than in the general population. And 20-30% become malignant over 20 years. Similarly, also for Crohn's disease. So this was the dietary and the other factor. Now, what are the other possible risk factors for CRCs? Viral infection, obesity, sedentary lifestyle, acromegaly, families with increased incidence carcinoma of other sites. We are not talking about familial colonic cancer, we are talking about other sites. And then, of course, the familial or hereditary risk factors, we just now said that the familial and the hereditary found in almost 1/4 of the patients. Now, the pathogenesis is important and it follows a adenoma carcinoma sequence. I've tried to make this very, very simple because the genetics of colorectal cancer is very, very complicated and beyond your scope. I just try to make it very simple, spread over only 4 or 5 slides. So let's talk about the adenoma carcinoma sequence. And we know that the CRC is a typical example of a sequence proceeding from a non-malignant adenoma gradually with a multi-hit theory. There are multiple hits to the gene leading to what? Ultimate genesis of carcinoma. So it's not a single hit theory. There have to be multiple genetic mutations. Remember, one single genetic mutation is not going to give rise to a carcinoma. So the adenoma goes on to become a carcinoma. That sequence is followed in an orderly fashion only under the effect of multiple hits at the genetic level, meaning multiple genetic mutations. Now, what is the evidence in favor of that? Number one, age prevalence of adenoma and carcinoma is actually similar. Carcinoma patients are 5 years older. That means if you start the genetic mutation today, 5 years down the line, your adenoma is going to change into carcinoma. Site distribution of both polyps and CRCs are almost the same, right? The histopathological examination of small and early CRC will always show adenomatous tissue. Excise 1/3 of CRC specimens, they have adenomas. Sporadic and familial adenomatosis polyposis polyps are identical, and FAP has an associated 100% risk of developing CRC. So all these are evidences. Larger adenomas have higher incidence of dysplastic changes. So all these evidences which are favoring the adenoma carcinoma sequence. Now, if you look at the types, we just now said sporadic almost 3/4 and the rest almost 1/4. So among the sporadic, there's no family history, common age above 50. If you look at the inherited group, about 6% of cases, hereditary non-polyposis CRC, also known as the Lynch syndrome, is the common type. The less common types are those found with multiple polyps of CRCs. Multiple polyps, the prime example is, of course, the familial adenomatous polyposis syndrome. You can have the hematomatous polyposis syndrome, which we talked about last time. Remember, Suits-Jeghers syndrome, juvenile polyposis, and of course the MAP syndrome. Familial 25%, and as opposed to inherited, you have a family history, but the pattern is not consistent. In an inherited, it has to be consistent pattern. That means father is infected, the child has to be infected. In familial, it's not so. The father is infected, the child may not be infected, right? So the pattern is not consistent, and the risk is not as high in an inherited syndrome. But still, the single affected first degree relative is at a 1.7 times increased risk, and two affected first degree relatives of patients, when they die before age of 55, they are at increased risk of malignancy. Now, we're talking about genetics. Now, what about genetics? Two things to remember. Number one, that the genes and the pathways which cause the malignancy, that means we just now told you multiple hit theory. So that means the gene has to pass through some pathway to ultimately give rise to a malignancy. Now, this can be found both in sporadic, hereditary, and mammalian. Let this be very clear in your mind. The genetic alterations are there even in a sporadic, may not be identifiable. In a sizable population, ultimately you may be able to identify, but genetics are prime movers of hereditary and familial CRCs. They are not the prime movers, or they may not be the prime movers of a sporadic CRC. This, in a nutshell, is what you have to remember. The pathways, how do the gene ultimately go on to form malignancies? Two very common pathways are found. Just remember them. Don't go into the details of them. Number one is the CIN pathway, that is the chromosomal instability. That basically means that you're losing heterozygosity at one particular site of the gene, 85% loss. And the second is if you have a mismatched repair gene. When your DNAs are multiplying, they have to match each other. Now, they may be mismatched. Now, when you have a DNA mismatch, that is harmful for the body. Though you've got repair genes, those genes will immediately repair that mismatched DNA. Now, if the gene which is going to repair the mismatch is impaired, the function is impaired, that would be known as microsatellite instability. So the two prime pathways, genetic pathways by which a person's gene develops into a malignant is a chromosomal instability pathway, and number two is the microsatellite instability. Very low or very rare cases of other changes or pathways are seen, like for example the CIMP pathway. If you don't remember it, don't worry, but just remember the MSI and the CIN pathway, microsatellite instability and chromosomal instability pathways, right? In both these, CIN and MSI, the earliest event, which gene is being affected? It is the loss of function of the APC gene product. And there is a difference if you have a CIN pathway alteration and a difference in the MSI alteration pathway. The clinical manifestation is also different. Like for example, if you have microsatellite instability leading to your CRC, you're more likely to be having a right-sided malignancy, and you are at a better prognostic level. As opposed to, suppose if I have a CIN pathway instability, I would be having more left-sided and I would be having a poorer prognosis. So that is just an extension of the clinical implication of a CIN or MSI pathway. So we know now what how the gene is going to be altered. But which gene are we talking about? What are the genes affected? We know that the gene is going to be affected by what? By the chromosomal instability and MSI or microsatellite instability. But what gene? Which gene? Is a hypothetical gene? No. The specific genes. Number one, tumor suppressor genes. Number two, mismatched repair genes. And number three, oncogenes. Now you have to remember these genes. Why? Because they are now in the mainstream of understanding CRC, even at the undergraduate level. So you have to understand the important tumor suppressor genes responsible for CRCs. And the most important, of course, is the APC gene. We have been talking about the FAP syndrome, that is the APC gene, mutation seen in 2/3 patients of colonic adenomas, right? And 60 to 80% are sporadic. See, even a sporadic, you have the genetic, may not be identifiable, but it is there. The second gene in the tumor suppressor gene group is the P53, TP53 gene producing the P53 protein. And then, of course, other rare genes. But these two you have to know, the tumor suppressor gene, APC gene, and TP53 gene. Then the mismatched repair genes, I just now told you, which are going to repair your mismatched DNA or the caretaker gene, which are prime movers of the Lynch syndrome. And they have to be remembered. And these are MSH2, MSH6, both on chromosome 1, and MLH1 on chromosome 3. If you don't remember them, refer to the last lecture. We have talked about the Lynch syndrome in great detail in the last lecture when we're talking about the colorectal polyps. And then the third group of genes affected could be the oncogenes, the KRAS proto-oncogene, the RAF gene, and P30K gene. So now we understand the genetics of a CRC. We know which genes are usually implicated. We know which pathway these genes are going to go ultimately to reach a point where they convert into malignancy. And we also know that a total 100 patients of CRCs, how many would be having a genetic alteration, how many would be sporadic, how familial, and how many would be having a inherited syndrome. Now, just a few words about the APC gene, because this is the most important gene being affected, and you find it the earliest mutated in the adenoma carcinoma sequence, located on chromosome 5, and the pattern of mutation is both phenotype aberration and genetic aberration. That basically means even the physical appearance of the gene is going to be altered in the form of aberrant crypt formation, and genetic aberration in the form of an abnormally short protein known as APC truncation. That means the gene size decreases, it decreases. That's why it is a short protein known as APC truncations. These types of mutations you may afford to forget. If you want to remember them, they are in front of you. You can remember them. If you want to forget it, forget it. But just remember that the APC gene is the most important gene to be affected, located on chromosome 5, and in almost 85% of sporadic cancers also. In all inherited cancers, so always there. But even among the sporadic, 85% will be having an alteration of this APC gene. Right? So just a few words about what we are talking about, the sporadic and the hereditary we refer to even in the last slide. So here, remember, just to recapitulate out here, that in a patient who is sporadic, to understand much better, idiopathic, it may not be having a genetic defect, or that person with sporadic CRC may be having a spontaneous APC mutation, or he may be having a double mutation. So all the three things are possible in sporadic. Hereditary, no. Hereditary, every patient would be having a genetic mutation. In a sporadic, every patient need not have a genetic mutation. He may be having a genetic mutation, he may not be having a genetic mutation, or he may be having a double mutation. But if you're looking at the hereditary CRC, they would all be having genetic mutation, either presenting as a syndromic or a non-syndromic clinical syndrome. And the common hereditary types we talked about were the Lynch syndrome and FAP syndrome. That mutated FAP and familial CRCs are less common. Let's talk about the site of CRC. So that meant about the genetics of CRC. That was important. That was the minimum which was important. That's why I just covered it up in a very short and concise fashion. Now let's talk about the site of involvement. And the most common site of involvement of the CRC, remember we talked about the colorectal cancer, is the rectum and the sigmoid. Among all these, the sigmoid is only 21% and rectum in 38% of cases. So if we look at the totality of colorectal cancers, rectum is much more involved than the colon. Okay, now let's talk about the other parts of the colon. Cecum 12%, If you look at the ascending, descending, and transverse colon, they all roughly between 4 to 5%. See this figure? That way it would be easier for you to remember. Ascending colon, transverse colon, descending colon, all about 4 to 5%. Flexures, hepatic flexure, splenic flexure, 2 to 3%. You can remember this much easier, right? Now, among the rectum, does it have any predilection for the upper third, middle third, or lower third? No, no specific predilection. We'll be talking about rectal carcinomas in a separate lecture that in itself is a separate topic. But here, just because the pathogenesis was absolutely the same, so we covered it as a CRC, right? Or a colorectal cancer. Now, as a generalized incidence of anorectal malignancy, we can say that the left-sided colonics are 3/4 and the remaining are right-sided. So the picture that should be in your mind should be absolutely clear that the left-sided colon, right down from the splenic flexure up to the rectum, is the more commonly involved part of the rectum and the colon in 3/4% of the 3/4 of the patients. Multiple growths, we already said, could be seen in around 3 to 4% as synchronous or metachronous. Synchronous basically means what? At the same time. So when you're identifying a rectal carcinoma, it is mandatory that you do a colonoscopy. Why? You say, I already have a rectal carcinoma in front of me. Why should I go and look at the colon? No, you should. Why? Because there could be a second primary, which is known as a synchronous primary. Synchronous basically means at the same time. Or you can have a metachronous appearance. You have taken all trouble at that time, you didn't have anything, you treated this patient, and 5 years down the line, now he has a second colonic malignancy in the ascending colon. So that is a metachronous. So these multiple growths could be found in 3 to 4% of cases. Now, if you look at the gross pathology, the gross pathology basically is either as an annular, a tubular, annular tubular, as an ulcerative, or a cauliflower. But along with this, you should always remember that polyps can also be malignant. So it could also be a polypoidal malignancy. These four, everybody knows. They're the four common. These are the common macroscopic, not the only. So apart from these four common, the other is a polypoid malignancy, and you can have a diffuse infiltrating, which may be resembling a cauliflower, or you can have a colloid form, which is a heavy, bulky malignancy involving all layers without any ulceration to start with. As a rule, remember that this is very important. Left-sided CRCs are obstructive, and that gives you an idea that if you have a left-sided colonic malignancy, the presentation, the clinical presentation would be absolutely different, right? And it is presenting in the form of obstruction, either subacute or acute obstruction, altered bowel habits, or as bleeding. As opposed to the right side CRCs are non-obstructive, and they will always present either as asymptomatic with features of consumption in the form of anemia, dyspepsia, weakness, or which is asthenia, or the patient can present with a mass in the ascending colon or the cecum, but obstruction is usually not a feature of presentation of right-sided colon. So remember that right-sided colonic malignancies, the presentation is non-obstructive, non-specific. Left-sided, obstructive, either partial or total or hemorrhage. A right-sided colonic malignancy usually never presents with hemorrhage. So that means hematochezia will never be a presentation of a right-sided colonic malignancy. It can be a presentation of a left-sided colonic malignancy. Is this clear? This has to be absolutely crystal clear, and that is very, very important. That as soon as you land up with some kind of a, let's say, hematochezia, and you start saying that this patient could be having a right-sided colonic cancer, doesn't make sense at all. Why? Because the right-sided colonic malignancy is never going to present with hematochezia. You know what hematochezia is, fresh blood on the stool. So that would only be possible if you have a left-sided colonic malignancy, much more common if you got a sigmoid or a rectal malignancy, or even a descending colonic malignancy, but never in ascending colon or a transverse colon mesentery. So remember, this is the reason why you have to remember the differences of presentation of a right-sided colonic malignancy and the left-sided colonic malignancy. Let's talk about the histology. 90% of all colorectal carcinomas are adenocarcinoma. That leaves 10%. And what are these 10%? 10% are neuroendocrine tumors, including carcinoids, and lymphomas and the GIST tumors, and the other rarer soft tissue sarcomas, right? So this is basically the 90% and the rest 10%, which could be epithelial tumors or could be non-epithelial tumors, right? Now, coming to the subtypes of the adenocarcinoma. So we just now talked about the adenocarcinoma, and now we have the subtypes of the adenocarcinoma. And what are the subtypes of adenocarcinomas? In order of commonness, the three most common types are the mucinous, which is colloid adenocarcinoma, the signet ring type, or the squamous tumors. Squamous tumors usually on the left side, which present as annular or present as tubular, or they can present with infiltrating. These are all squamous tumors, right? The rest other types identified, these are all adenocarcinomas, remember, all adenocarcinomas, medullary, micropapillary, serrated, and so on and so forth. You can look it up. Ultimately, you can also have a up to the undifferentiated type or a mixed type, which is the adenosquamous, which has got both types of tissues. That means both adenomatous tissue and the squamous carcinoma. The histological feature, if you look at the histology, how do you identify these? You will find a typical granular pattern of differentiation, and the basis of differentiation based on the broadest classification, you can classify them as well differentiated, moderately differentiated, and a poorly differentiated when you have less than 50% gland formation, and that is seen in 20% of all colorectal adenocarcinomas. Now, when would you say a colorectal carcinoma is invasive? This has got a very, very clear-cut definition. You would call a colorectal carcinoma invasive pathologically, remember, not clinically. Clinically, of course, in front of you, you have a T4 disease, is gone beyond the serosa, it is an invasive carcinoma. But pathologically, when would you term a malignancy as invasive? Number one, when it has gone beyond the muscularis mucosa into the submucosa. That means broken the confines of the innermost layer of the mucosa and now gone into the submucosa. Number one. Number two, that particular specimen should be having a desmoplastic or fibrous tissue surrounding the tumor cells. And number three, the characteristic necrotic debris in the glandular lumen, also known as dirty necrosis. So remember, three facts are important, or 3 points are important whenever you want to classify or call histologically a CRC as invasive. You have to have spread beyond the muscularis mucosa, fibrous tissue, and number three, dirty necrosis. All three things should be identifiable. Only then pathologically on a specimen you can say, look, your patient is having a invasive carcinoma. You have to be on the lookout, and you should temper your treatment along with it, right, based on that. Now, what is the invasive carcinoma? Just a few pictorial explanation to you. So this is the epithelium, this is the lamina propria, and this is the muscularis mucosa. Together, this makes the total mucosa. So you got the three layers of the mucosa: the epithelium, the lamina, and the muscularis mucosa. So once it breaks the confine, so until you have a tumor localized to this particular layer, that is the mucosal layer, that means limited by the muscularis mucosa, it's not gone beyond the muscularis mucosa, it should go beyond it to be called as T1. That means if you have infiltration into this layer, see this layer, the submucosa, see the pointer, there's a submucosal layer. So when you have it in the submucosal layer, that would be known as T1. Now, why did I put this here? Invasion of the submucosa. Now, this is very, very characteristically different from the other parts of the GI. In the other parts of the GI, a PTI or T1, a T1 in other parts of GI is a mucosal invasion. That means in the apart from colon, if any other part of the GI is involved and you've got involvement of this layer here, that would be T1. Not so in colon. In colon, it has to come up to this layer, only then you like to call it as a T1. That is the difference. And why is this difference there? Probably because the lamina propria of the colon has got very sparsely situated or lymphatics inside this. So if there are less of lymphatics and less of vascularity, there will be less dissemination. And that is why conventionally in all classifications, In colonic cancers, you'll find T1 to be when there is a submucosal involvement, as opposed to, let's say, esophageal or let's say a gastric cancer, where even the mucosa involvement would be known as T1. So if you don't call T1, if you don't call the mucosal involvement as T1, what do you call it in the colon? In the colon, you term it as a high-grade dysplasia, or according to the American classification, you call it as carcinoma in situ, so that is T1S. So remember, in colonic cancers, the mucosal involvement is T1S, as opposed to other GI cancers where mucosal involvement is T1. Simple, one single sentence. Remember that, and I'll give you the reason why. So, but remember, this discrepancy in classification, you have said one mucosa, the other submucosa is T1. In one you say mucosa is T1, in the colon you say submucosa is T1. Does this discrepancy in classification really affect the therapeutic decision making? No, it should not. Why? It has to be seen in a broader base, and that broader base basically means that you have to see the bulk of the tumor, you have to look at the gross appearance, you have to look at the endoscopic ultrasound findings. That means in totality, it has to be a holistic approach and a holistic view before you can say that this T1S is really T1S and the T1 is really T1. Is that clear? But this differentiation is important. So what are the pre-malignant lesions? Number one, we already said polyps, either solitary or multiple, like in a polyposis syndrome. In the non-polyposis, the pre-malignant condition, last time we talked about that, that was the hereditary non-polyposis colonic cancer syndrome, that is the Lynch syndrome, and of course the IBDs, which are important pre-cancerous lesions. How does it spread? Number one, direct continuity through the bowel wall. Remember, it always spreads longitudinally, and it will also spread radially. Now, radially, it will spread beyond the serosa into the extraserosal into the peritoneum if it is an intraperitoneal part of the colon. But like, for example, let's say the descending colon or it is the ascending colon, then it has to go into the retroperitoneum. So, retroperitoneal involvement would be found in those parts of the colon which are the fixed parts of the colon, namely the ascending colon and the descending colon and the rectum. But the other parts of the colon, namely the transverse colon, the sigmoid colon, you would be having, even with a radial extension, it will always be inside the peritoneum, not retroperitoneum, right? Now, the radial extension in the colon is limited for a long time, and it usually causes internal obstruction before it has penetrated adjacent structure. So what does it tell you? It basically tells you that when it is causing a radial extension, before that it becomes so bulky that there is always a luminal block. So luminal block will occur before the spread becomes a T4 spread. Is that clear? That is true for the left-sided malignancies, which make 3/4 of the malignancy. Remember, I told you 3/4 malignancies are left-sided. The second method of spread is transcoelomic, that is into the peritoneal cavity, where you'll find the studded peritoneal nodules, or you can find the tumors, the crooked tumors over the ovary, or the metastasis that you find in the pouch of Douglas. All these, or the rectovesical pouch, these are all evidences of transcoelomic spread. Then comes the bloodstream spread, and the bloodstream spread we all know is into the liver, seen in 33% of patients at the time of diagnosis, and the second common is the lung. Other rarer sites, bloodstream, remember, ovary, brain, kidneys, bone. And then, of course, the lymphatic, which is very, very important. We'll just talk about the lymphatic in the next slide. Implantation onto a raw surface or suture line in the bowel is also a method of spread. You've done an anastomosis, and you can find at the suture site implantation of malignant cells. So these are the methods by which it spreads. Now, let's talk about the lymphatic. Why lymphatic? Because lymphatic spread forms the cornerstone of future therapy of a colonic cancer. Right? Now, the lymphatic pleasures, where are they found inside the colon? Number one, we already said in the lamina propria, but very sparsely. So there's hardly any in the lamina propria. They are there. But then some mucosa has it, the intermuscular layer has it, the subserosal layer has it, and the subfacial planes has it. That means extraserosal between the serosa and the visceral peritoneum. All of them have got very rich lymphatic plexus. Lamina propria doesn't. So thus, beyond the macroscopic limits, you will always be having microscopic spread, because it's got such a rich lymphatic network that you'll always be having microscopic. You may not be able to see it on the, you've opened the abdomen and you find that there's a growth in the ascending colon. You start looking for nodules, you may not be able to find them. But be sure that the lymphatics may be involved microscopically, which are not evident macroscopically. So what predicts whether your lymph node is involved or not? Number one, if you've got a poorly differentiated malignancy. Number two, the depth of invasion. Very obvious. The T staging. T2 will have more lymph nodes. T3 will have more lymph nodes. T4 will have even more lymph nodes, right? Then, if you look at the percentage of these T1, T2, you'll find that T2 and T1 would be having a lymph node incidence of almost 20%. While T3, T4, if you've got a growth of T3, T4 type, then you got 50% lymph node incidence. So it depends upon the T staging. The number of lymph nodes, why is it important? Because that can be made to correlate with the stage of the disease and the survival of the patient. And if you've got more than 4 positive lymph node mets, either histologically or overtly, that means by naked eye, that patient be sure would be having a poorer prognosis. This was also covered when we started about the anatomy of colon, but I'm going to repeat this here. Why? Because this becomes very, very important in the scenario of colonic cancer. And this is basically, I told you, just remember the 2 mnemonics, or rather 3 mnemonics, either Apc, Pic, or PID. I always try to remember with the Apc. E basically means the epicolic, paracolic, intermediate, and central. So epicolic are found on the walls of the colon. The paracolic are these, intermediate are these, and central are those from where the vessels are arising. This is the area of the vessel, so these would be the central vessels. And depending on the site of the cancer, the appropriate or the draining lymph nodes would be involved. I'm not going to repeat this. All these, you can see it on the slide in front of you, right? But just you have to remember 2 or 3 facts. Number one, that the total number of lymph nodes which are draining the colon are somewhere in the region of 100 or 150 lymph nodes which drain the whole of the colon. Around 150 lymph nodes. Remember, that's a very big figure. And whenever you have to do a dissection of any type of colectomy, the minimum number of lymph nodes that you should remove should be at least 12. Remember this. This is a standard established, still being followed, and that is harvesting of 12 lymph nodes in any colectomy for cancer. Remember, not for, say, for tuberculosis of the ileocecal region. You're doing a hemicolectomy, you say I have to remove 12 lymph nodes. No. It is for any kind of colonic cancer, minimum number of lymph nodes to be removed or harvested should be at least 12, right? The second mnemonic was the PID, that means the proximal, intermediate, and distal. But this, I believe, is a better mnemonic by which you can remember it. And these are the lymph nodes. Just you can see this on a slide. Now, coming to the Japanese classification, and the Japanese are adept at classifying any GI into a huge number of lymph nodes. Here also see the number of lymph nodes that they're given, 221, 223. So they start labeling it right from top and they go around up to the bottom. So here also, basically, these are the pericolic. The red ones are the pericolic. Then these are the intermediate. We already talked about the EPIC. So this is the paracolic. This is the epicolic. See, epicolic on top. Then you got the paracolic. Then you've got the intermediate. And these are the central group of lymph nodes, which are basically are in and around the central vessels or at the origin. So these are the central lymph nodes. So this is basically what makes the whole of the lymphatic draining. Now, how do you diagnose a CRC? Endoscopic is the gold standard, and you can do either a proctosigmoidoscopy, which can cover up to 25 centimeters of your colon, or you can do a flexible sigmoidoscopy, which can extend up to 60 centimeters, and you can cover up to the splenic flexure. These figures are important. Just note them down, or just remember them. That's very important. With a colonoscope, you can go from the dentate line up to the terminal ileum. Remember, you can also go beyond the ileocecal region with your colonoscope. That should be absolutely clear in your mind. And it also allows a biopsy. So with a proctoscope, a proctosigmoidoscope, a sigmoidoscope, and a colonoscope, they will all give you different lengths of colon which can be accessible for visualization and for biopsy. You can do a contrast study also. So this was direct visualization. I can see what I'm looking at. I can see whether there's a growth or not. But short of that, I don't have a colonoscope. The gold standard is not there. Now what can I do? Now I can do a contrast study, and this contrast study is always better if I do a double contrast. I mean two contrasts. And the most common two contrast is either an oral or barium contrast, which is barium or an alternate oral contrast along with air. So that means now you're two things contrasting. You got the contrast in the form of either oral barium or any other agent, and number two, you pushed in air. So AA double contrast study, also known as AA double contrast study. It can identify perforation for you. A double contrast is 90% diagnostic for polyps more than 1 centimeter in size, and the typical formation is an apple core deformity. This is when you eat an apple, it looks something like this. And if you look at this, see this part, it looks like an apple core. So this is a typical apple core deformity, which is found in a patient where you're doing a double contrast in a patient for colonic cancer. Now, can there be other imaging techniques? Yes, a spiral CT, a virtual colonoscopy, polyps as small as 6 millimeter size can be identified. A CT MRI for staging purposes, very, very important. Why? Because if you want to identify the degree of lymph node involvement, you want to do a preoperative staging. I want to know the degree of lymph node involvement. Ultrasound is not going to tell me that. So what do? I do a CT or an MRI. A PET scan will tell me which parts of the body are also involved. That means up to what level the mets have spread. And it can also tell me whether a scar which has got a nodule over it, the patient had let's say colonic cancer 5 years back, and now it comes to you with the scar in the abdomen and there's a nodule on the scar. Now that could well be a colonic metastasis on that scar. So how do you differentiate? It will differentiate by a PET scan. So PET scan helps you to overall picture of the body, telling you about the level of met spread, what parts of the body are involved, right? So that is what is important of the PET scan. And ultrasound, if you're doing it as a transrectal ultrasound, especially for rectal carcinoma or endoluminal ultrasound, then that can help you with the T stage, staging. Otherwise, it will not help you with the T stage. Coming to the classification, and I told you the pragmatic classification, time-tested classification is the Duke's classification. Very, very easy to remember. Just see this figure. Still used by a lot of centers. So here, limited to the mucosa. See, stage A, B through the muscularis mucosa, B2 muscularis propria. That means proper muscular layer. B1, B2. You add lymph node to B1, it becomes C1. You add lymph node to B2, it becomes C2. Simple. B1 plus lymph node, C1. B2 plus lymph node, C2. Is that clear? So if you have lymph node, B1 becomes C1, lymph node B2, C2. And then D is distant metastasis. D, the name itself says distant metastasis. So this is a very easy to remember classification, and it has gone a number of modifications since inception. And the one which is now being followed is what is known as Askler-Kohler's modification. Just remember Askler's modification of Duke's classification, right? Now, what are the additional variables for staging apart from the T and the N staging? You can also look at the venous invasion. V1 is microscopic venous invasion. V2 is macroscopic. You go in and you're looking at ascending colon malignancy, and you try to palpate the artery and the vein. You find the vein is full and it is thick with some kind of a emboli in it. That is venous invasion. Lymphatic invasion. Already talked about the L staging. Histological grade is the pathological grade, and we said the degree of glandular differentiation to help you in trying to differentiate whether it's well, moderate, poor, or undifferentiated. Now, a simple Pnm classification. This is picked up from Love Bailey. It tells you T1 submucosa, muscularis propria. I'm not going to read this out for you. Just go and look it up. N1, just remember, is 1 to 3 lymph nodes. N2 is 4 or more lymph nodes involved. This is a much more detailed classification. And why? This is a classification. This is more detailed TNM, and it is reflective of survival outcomes. Now, at present now, whenever we talk about the 5-year survival rates, we always talk about the SEER registry. For any malignancy as of now, you go take up any book, you read up any malignancy, you'll always find the SEER figures. What does SEER stand for? The SEER stands for Surveillance, Epidemiology, and End Results. This is a registry which is a statistical compilation of malignancies, and then they give out the figures of the survival rate, the figures of mortality, morbidity, etc., etc., etc. That's why it is known as a registry. It's a registry. So it is a tabulation of the data. That's why it's known as surveillance. You survey the epidemiology and then you give the end results, right? So that is why the SEER registry. So for the SEER registry, the Pnm classification has to be much more detailed, and this is what is the detailed classification. So coming on to this, I'm not going to go to the details, but just few things which are very clear and can be pointed out. That is that until you have any kind of lymph node involvement, if there's no lymph node involvement, it is immediately less than 2 or less. That means 1 and 2, there is no lymph node involvement. 1 and 2, no lymph node involvement. Stage 3, lymph node involvement. Stage 4 is M1. Remember Dukes? C is what? Lymph node. D is what? M1. So here 3A, 3B, and 3C are what were B1, C1, and C2 in the Dukes classification. And B1 and B2 are what are stage 1. Right? So stage 1, stage 2, stage 1 T1, stage 1 T2. Please switch your mic off. Somebody's got the mic on. Right. So remember, until you have lymph node, it is stage 1, 2. You have lymph node, it becomes stage 3, and Mets stage 4. That is how you can remember it very clearly. How do you screen for a CRC? As for colonic polyps, you just do the screening just like a screening for colonic polyp. Like for example, if you got a hereditary syndrome, you start a screening at 20. But in sporadic CRC, it is better to start, or it is conventional to start the screening either at 50 years of age or 60 years. 50 years appears to be a much more pragmatic age to be followed up. So in a number of Western countries, it is a rule that after 50 years, every adult is subjected to a colonoscopic surveillance. So that colonoscopic surveillance, and with that a fecal occult blood estimation. So two things are important for surveillance above 50. One, a fecal occult blood estimation, and number 2, a colonoscopy. And then of course, if the patient is a high, like for example, high risk, like for example, a hereditary or a familial patient, of course you have to go in and do a appropriate colonoscopic examination. The hereditary colonic syndromes, I'm not going to go into the details of those, but just remember, I told you as a Lynch syndrome is concerned, I told you the genes. I just now told you about all these genes. They're just a repetition of that. But in these, along with colorectal cancer, see, the right side is more common. In the other, is the left side is more common. Then you got attenuated NYH polyposis. These are the hereditary colorectal syndromes. Now, what are the principles of management? Surgery is the mainstay of therapy. Surgery, surgery, and surgery. It's simple. Radiotherapy, no role. Now we are talking about, see the change now in the title of the slide. It is CC. It is no longer CRC. Be very careful about this. From now on, we are talking about the CC. The treatment is only of CC, not CRC, because CRC radiotherapy has a role in rectal cancer. It has a role. So we are just sticking to colonic malignancy now. Surgery is the mainstay of therapy, and probably the only therapy. Chemotherapy and biological therapy plays an adjuvant role. The surgery can either be in the form of primary lesion, extended dissection, or surgery for met. We'll just go over that in very short. So if you got stage 0 disease, that which means mucosal dysplasia, remember I told you T1S in colonic cancer, I just now told you T1S. If you got a mucosal dysplasia limited by the lamina propria, then polypectomy with negative dysplasia, or if at all, you can go in for segmental dissection if required for negative margin. That means you're not able to excise the polyp completely, go in and do a segmental dissection. Nothing else is required. You don't have to go in for a formal colectomy. Remember that. But if you got stage 1, this is a malignant polyp. The first one was what? Dysplasia, dysplastic polyp. This is a malignant polyp. Here you have to do a polypectomy until you have got negative margin. If you've got If you don't have negative margins, again a segmental colectomy is required. So on colonoscopic examination, you feel that there's a deeper invasion, or on histology, you find a lymphovascular invasion or a poor histology. In all these cases, or if on resection margin, you find within 1 millimeter tumor is positive. In all these cases, you have to go for segmental colectomy. So remember, if you got T1S disease or T1 disease, it has to be a polypectomy with or without segmental colectomy. Is that clear? So here also segmental resection, here also segmental resection. Now coming to stage 2 and stage 3. Stage 2 is what? A localized colorectal disease. So this has to be surgery plus adjuvant chemotherapy. See, stage 1 and stage 0, 1S, there was no role of adjuvant. Now here you have adjuvant chemotherapy. So stage 2, all stage 2, especially in those who are high risk of local and distant recurrence, like for example, those with poor histology or younger patient, like say patient has got 40 years, he has colonic cancer, 20 years, he has colonic cancer. You can be sure he's a very poorest patient. So and then you have to combine adjuvant chemotherapy as opposed to, let's say, a patient who's about 70 years of age, there you may not like to combine adjuvant chemotherapy. Stage 3, lymph node mets. It has to be a much more extensive surgery and adjuvant chemotherapy has to be done. What about stage 4, metastatic? Does it have any role of surgery? Yes, still has a role. There it is a palliative surgery. Palliative surgery in the form of either tumor reduction surgery, or you can be doing a stenting, you can be doing a permanent colostomy, or you can be doing a bypass stoma. But else, otherwise, the primary therapy in those patients would be now systemic chemotherapy, and surgery becomes an adjuvant therapy, right? You can even go in and do a surgery for the METs, that is metastectomy, and that is metastectomy is basically either you're removing isolated liver mets, or if it is say involving one lobe, you're doing a lobectomy, or you can do an isolated lung mets. So it depending upon what is the clinical presentation, what the pathological presentation, there you have to go in for some kind of a cytoreductive surgery. And if you got a generalized peritoneal metastasis, there is a role for HIPEC, that is intraperitoneal chemotherapy. Now, the principles of surgical resection. What are the principles of surgical resection? Remember one thing, that lymph node involvement, I told you that there are very three rich networks: the submucosal network, the muscular network, and the subserosal and the extraserosal networks. All these networks are very, very rich networks, right? And because the spread most certainly, now you can well say that yes, this is an orderly fashion. Lymph node 1 involved, then this gets involved, then the blue gets involved, then the yellow gets involved, and then the white gets involved. Agreed, it does. That it usually does follow that pattern, but it is not the rule. It is not the rule. And in quite a few number of patients, there are skip lesions. So that basically means that spread more distally is uncertain. And because it is uncertain, so wider excision has to be done. So even if you're not finding a lymph node palpable here, you may say that, look, I'll just remove this part. I don't find any lymph node here. I don't find lymph node here. That may be a wrong decision. Why? Because that lymph node may be involved after all microscopically. So basically, because more distal spread is uncertain, so there you have to go in for a more wider excision. Now, because the lymphatics are accompanying the vessels, a wide excision means what? That you have to clear the vessel right at the base, the supplying artery and the vein. That basically means the central vessels have to be cleared, whether it's ileocolic, is a middle colic, the left colic, or the sigmoid vessels, whatever. So they will have to be clear. And a minimum of 12 lymph nodes have to be cleared. So point number 1 that we now remember as far as the principal surgical resection is concerned is that it has to be a comprehensive lymph node dissection, which basically means you have to go right up to the central group of lymph nodes, preferably removing minimum of 12 lymph nodes. Point number 1. Point number 2, because the vessels have to be cleared at the origin, they often have to be ligated at the origin. And if you're going to ligate the vessel at the origin, all that part of the colon being supplied by that vessel, that means the artery and the vein, would have to be removed and blocked, right? So when you're removing the whole thing and block, the proximal part left behind and the distal part left behind, you have to be very sure whether the vascularity of those two parts is enough or not. Because remember one thing, as opposed to small bowel, resection in the colon is slightly more dangerous. Dangerous in the sense that it has got a poorer vascularity as compared to the small bowel. And because of that, the incidence of anastomotic leakage is much more in colon as compared to the small bowel. Now, when you talk about the vascularity of the colon, you've got these vessels, the ileocolic, you've got the middle colic, you've got the the left colic, and you got the sigmoid branches and the rectal branches. Now, all these branches are there, but do they anastomose? Yes, you have to understand that. And that understanding depends upon the two arcades. We'll just not talk about that. We also talked about that when we talk about the artery. You have to look whether the Drummond's arcade is functioning or not, whether the rheolon arteries are functioning or not, and the venous drainage is adequate enough or not. Now, along with that, I'm just telling you the principles. I'll just come to the details in the next slide. So the other principle is that along with the lymph node and the colon, would you like to remove something else? Yes, the omentum may have to be removed and blocked with the tumor if you find the slightest hint of any omental spread. And once you've done that, local irrigation with the cytotoxic drug may minimize the local recurrence. So that means the two edges which have been cut and removed, the two remaining edges may be washed with the cytotoxic drug. Not the rule, you may do that. Then you have to anastomose the two ends. And that anastomosis can either be hand sewn, which is still done by almost 80-90% surgeons. Rest 10% can use a stapled anastomosis, especially if you're doing a laparoscopic approach. And that brings us to the approaches. And you can do the excision, even colorectal malignancy. Remember that initial belief was that if you have CRC, any type of colonic cancer of any type, no laparoscopy to be considered at all. No longer so. There were two recent UK trials, the classic trial and the color trial, and they all shown that whether you do it open or you do it laparoscopically, if you're following the surgical principles of malignant resection, then there is equal recurrence rate, equal survival rate, and equal quality of life. So there's nothing to choose between the open and the laparoscopic, except of course the technical expertise that basically means whether the surgeon is able to do laparoscopically or not. And that's why robotic laparoscopic surgery is also come up in a major way when you're tackling the colonic carcinomas or colorectal carcinomas. Resection is also to be attempted with metastasis and should be determined by the location and bulk. I already talked about that, and the technical feasibility of the excision. It is to be considered even in high-risk patients. Like, for example, synchronous, we talked about the familial inherited syndrome. So patient comes to you with, let's say, FAP with CRC. What should you do in that patient? Should you do a right hemicolectomy or left hemicolectomy if that's indicated? No. The preference in that patient should be what? It should be a subtotal or total colectomy. Why? Because the entire colon is at risk. Remember that this is a very important point. Sporadic colonic cancer and non-sporadic, that basically means a hereditary colon cancer, it is much better to do a total colectomy or a subtotal colectomy for a hereditary colonic cancer as opposed to sporadic colonic cancer, where you may afford to do a lesser colectomy. Is this clear? This should be very, very clear. Hereditary cancers or those patients who got high-risk colonic cancer, they should be subjected to subtotal or total colectomies. Those at low risk or sporadic cancers can afford to go ahead and have a lesser procedure. Now, to understand this principle better, I talked about two things. This is a figure I showed even in the anatomy. We talked about the anatomy, just so that you remember it once again. And this is basically the ileocolic, the supply right from here, coming from here. So coming from superior mesenteric, the ileocolic and the middle colic, and coming from the inferior mesenteric, the left colic and the sigmoid branches. Now, they all have anastomosis out here, which is very important, and that is the Drummond artery. And the anastomotic point is usually here. That is the junction of the medial 2/3 or the right 2/3 and the left 1/3. And this is the area which is at the maximum risk. Why? Because often at this point, there may be no anastomosis. The second thing is anastomosis in the left colic and the middle colic, which is known as the arc of rheolon. So if you have these two present in one patient, you can be sure that this patient, the vascularity of the colon is very good, and you can afford to go in for a resection. So if you find arc of rheolon in a patient and you find the Drummond artery functioning in a patient, be sure that there you don't have to worry too much about the vascularity. Why? Because the marginal artery is going to take up the vascularity. So this is the marginal artery of Drummond. See this marginal artery of Drummond, and it is lying at a distance away from the colon. Remember when we're talking about the colostomies, where should you put the catheter to hook it up? We told you just at the side of the colon, not here. If you put it here, essentially what are you going to do? You're going to angulate the Drummond artery. That will lead to ischemia. So the catheter which is going to hook the colostomy up should always be at the margin of the colon rather than at a distance of the colon. So just coming back, the artery, remember to look for the Drummond artery and the arc of Rioran. Is that all? No, you have to look for the terminal inferior-mesenteric anastomosis. That means the sigmoid branches along, or the superior rectal branch, or the terminal branch of the inferior-mesenteric artery, that the superior rectal branches and the terminal sigmoid branches anastomosing with the systemic artery, and with systemic artery here, the internal iliac artery. Now, the important takeaway message from an arterial supply of the colon. Number one, you have to be very, very sure of the colon which you're going to anastomose, the proximal end, distal end. This was the colon, I removed this, and I've got these two ends to it, right? Now, when I want to anastomose, I have to see whether the anastomosis here or the bleeding here is enough or not. And for that, very simple, a naked eye examination often suffices. You can see the capillary ooze from the edges. If you don't see a capillary ooze from the edges, go ahead and do a further dissection. Remember that. That is a visual inspection. Now, suppose you're doing a laparoscopic surgery, you may not be able to visualize that very clearly. So there you can take the help of indocyanogreen perfusion, which can be seen with, as soon as you put in an IV bolus, seen as a green fluorescence, and tells you about the vascularity of the colon on a laparoscopic examination. The second thing to remember is that 2 centimeters of the colon can be stripped of its mesentery without hampering the supply of. What does this mean? This means if this is a colon, I've got the mesentery here. I can strip 2 centimeters off. So I've got 2 centimeters of colon without any mesentery attached, but still the vascularity would be there. And where is the vascularity coming from? From these submucosal lectures. Is that clear? So 2 take-home messages from the arterial supply. Coming to the venous supply, which is again very important, and we know the inferior mesenteric artery is important. It's behind the pancreas. Here is the pancreas lying here. It's going behind the pancreas and joining the splenic vein, where along the superior border of the pancreas. This is superior border of the pancreas. So it's going to join the splenic vein to form the portal vein. Now, this is a variable opening. It can join here, it can join here, or it can join at this point. So inferior mesentery can have aberrations of opening. Usually 90% of the time it's in the splenic vein. Lesser number of times it can be in the superior mesenteric. Even lesser times it can be opening directly at the junction of 2. One thing to remember is whenever you're going for any kind of left-sided colonic colectomies, you have to ligate the inferior mesenteric vein. And where do you ligate it? That is very, very important. The ligation is always at the inferior border of pancreas. So if the pancreas is lying somewhere here, it is going to be ligated. So you have to reflect the transverse colon. The whole thing has to be reflected up to this part, and then you find the pancreas and you ligate it here. Don't ligate the inferior mesenteric here. Doesn't serve any purpose. It's an incomplete colectomy for you. It has to be complete. You have to ligate the inferior mesenteric. And the inferior mesenteric anastomosis, we are talking about the vein now, not the artery. So if you have the marginal anastomosis between the veins, switch off the mic. So the marginal anastomosis between the inferior mesenteric vein and the branches transverse colon are depicted in 20% patients. That is important. And if you have one vein, the rest of the colon is going to undergo vascular. I think there's some disturbance to. Kindly switch off the mic. There's somebody talking in there. Kindly switch off the mic. So the marginal veins, remember the marginal vein of the descending colon is always very excellently present. And that is why, remember when we talked about the guiding part last time, this part can be broken up or for these. So the right colon does not form a very good substitute for the esophagus because the marginal vein lies. Okay. Now, the important vascular landmarks when you're going for the section is important. Ileopolypedic. Where do you see ileopolypedic? Where do you identify at the caudal posterior portion? So you have got the duodenum somewhere here. You identify it at the caudal portion of the duodenum. The mic was then you got the middle colonic vessel. There are the middle colic vessels originating from the superior mesenteric artery. And where do we identify them? At the inferior margin of the pancreas, middle colic vessels. Similarly, the inferior mesenteric vein can be either identified at the inferior margin of the pancreas or at the ligament of Tietz, which is very close. So here you got the ligament of Tietz. So at the inferior margin of pancreas, ligament of Tietz, you're going to find two things: the middle colic vessels and the inferior mesenteric vein. Then the inferior mesenteric artery, 2 to 3 centimeters caudal from where you find the inferior mesenteric vein. That means here the mesenteric vein 2 to 3 centimeters caudal to it, and then you have the left colic artery originating about 2 centimeters distally to the origin of the inferior mesenteric artery. So that is how the vascular landmarks are important. Now, what are you going to remove when you're doing a coronary carcinoma? If you got a cecal carcinoma, see the parts I've labeled out. These are the parts to be removed. Cecal carcinoma, you remove up to this part, transverse colon. This is known as the right hemicolectomy. Or you can do extended if you got hepatic flexure. You have to remove this part, remains the same. You have to go more toward the left side, right? That means more of transverse colon, splenic flexure, descending colon, and sigmoid colon. So the parts have been shown in the diagram. What is to be removed? You can find them even Schwartz Principle of Surgery, 11th edition. The page number is given out. You can find them there. So these were the routine colectomies. Now you can also go in for extended hemicolectomy. Now what is extended hemicolectomy? Now look at these two black lines. A hemicolectomy would be from here to here. An extended hemicolectomy means extended level of the transverse colon. That is an extended hemicolectomy. The two black marks. And then you got a extended left hemicolectomy. Right from here up to the transverse colon junction of third and 2/3. So now the left 2/3 and right 1/3. And then you've got a total colectomy right from A, removing the total colon right up to the sigmoid and just leaving the rectum behind. So that is a total colectomy. So these are extended colectomies. So the normal colectomies were the colectomies that we showed for malignancy. The right colectomy, the left colectomy, the transverse colectomy, and then you got the extend or the sigmoid colectomy, the descending colectomy, and these are the extended colectomies or the subtotal and the total colectomies, right? Now, the main intent is what? Removing the damaged part or removing the pathological part. You can have a delayed or secondary curative intent, and that would be that at first stage when the patient has come to you, he's in a poor general condition. So what do? At that initial stage in emergency, like an emergency, or the patient got a very fixed growth or a poor general condition, you do a temporary procedure, put this patient on adjuvant therapy, nurse the patient back to better health. Or if you're an inexperienced surgeon, you can't do a colectomy, at that point of time, you have to go in for another palliative procedure, and you do just do a bypass, come back out, and then later on go in for a secondary intervention in that particular patient. So primary, it should be a temporary job, and later on you go in for the permanent job. So that temporary job could just be creating a proximal ostomy, ileostomy, or a proximal distal side-to-side bypass, and then go back and when you are more experienced, or rather when the patient is in a better condition, or you got a more experienced surgeon with you, then go ahead and do a curative intent. Now that was about the surgery part. Now what about the chemotherapy, adjuvant therapy? The adjuvant therapy basically is 5-FU, capecitabine, irinotecan, and oxaliplatin. So these are the four basic drugs. 5-FU, capecitabine, and irinotecan, and oxaliplatin. So these are the four basic drugs, and they are either used separately or in combination. And the two common drug combination used is the Capox combination therapy and a FOLFOX therapy. Just remember these. You may not just remember what are these. You may not like to remember the whole of the regime. The PG should. So the FOLFOX regime is the most common regime used, and you should know that it is oxaliplatin, the folinic acid along with fluorosil, and fluorosil. That's why it's FOLFOX regime. Now that is given in stage 3 and beyond as 12 cycles every 2 weeks, right? And this is one cycle. Every 2 weeks you have to administer that. What about the biological therapy of colorectal cancer? Now, one which is a humanized monoclonal antibody, bevacizumab, and that is an angiogenesis inhibitor. So you're using a biological therapy here. It is basically a vascular endothelial growth factor inhibitor, and it is now being approved even by the FDA for use in metastatic cancer. Now, prognostic factors of CRCs, polyp, characteristics of polyps, you got the pedunculated growth, the chances of malignancy. This I think we've covered in the colorectal polyps. Right-sided growths have better prognosis. T staging, very obvious, would be having a better prognosis if it is T1 versus if it is T4. Lymph node, again, very obvious, but what is less obvious is the degree of excision of lymph node. So the more extensive the lymph node excision, the better the prognosis, right? The vein invasion, if it is there, poorer prognosis. Histological grade, again, it has got a doubtful role, but yes, if it is a poorly differentiated, it has got a poor prognosis. Intestinal obstruction, presenting intestinal obstruction or other emergency condition, in these, the survival is probably the same, but mortality rate increases. What do you do if the patient has got hepatic metastasis? In a patient who got hepatic metastasis, a primary excision is always advisable as a tumor deloading surgery, and 12 weeks after primary section, go ahead and restage the hepatic metastasis, and then if there is less than 3 mets in a particular lobe of the liver, go ahead and do a resection of the liver, either as a trisegmentectomy or a lobectomy, or even less as a segment of the liver. So either one segment, more than one segment, or 3 segments, right? So one segment, one lobe, and one lobe plus one segment is known as trisegmentectomy. 5-year survival, even with hepatic mets excision, is 30%. Just a few words about the GIST. I'll just like to finish this. I'll just take 5-10 minutes more. GIST of the colon, and they make up 1 to 3% of all GI malignancies, 5 to 15% colorectal. That means the GIST are 1 to 3% of all GI, and among all these 1 to 3%, of these 1 to 3%, only 5 to 50% are colorectal. So they are an uncommon site. 30 to 50% of GIST are malignant, multicentric in less than 5%, any age, but most commonly found in adults. Now the colonic GIST, initially they were also known as leiomyoma, leiomyosarcoma, schwannoma, but they are now known to be distinct. These were misnomers. A leiomyosarcoma is distinct from a GIST. It is not a GIST. GIST is absolutely different. Initially, there was a tendency to combine the two, saying that a leiomyosarcoma is just a GIST. No, it's not. So these GIST, they arise from the interstitial cells of Kajal. They are known as ICC cells, and they're part of the autonomic nervous system. They occur as sporadic, rarely hereditary, as opposed to CRC, which are hereditary in almost 25% of cases, familial and hereditary 25% cases. These are mostly sporadic, less commonly hereditary. More than 95% have c-KIT gene mutation. There it was the basically mutations of APC gene, the P53 gene, and so on and so forth, MSH genes. Here it is a c-KIT gene mutation leading to production of what is known as the KIT protein or the CD117 product. That is the product. So that's also known as the KIT positive. So ICC is also known as a KIT positive. And because they are KIT positive, they are sensitive to tyrosine kinase inhibitors, which the most common one uses imatinib miscellany. So they are all susceptible to TKIs, the tyrosine kinase inhibitor is also known as TKI. If you have a normal CK kit, you may be having a mutated PDGFR, that is a platelet-derived growth factor alpha gene, which is mutated. So either 95% you have a c-KIT gene mutation, very less commonly you can have a PDGR alpha gene mutation, right? They are all CD3 positive and Desmin negative. Pathophysiology of this, there are two types histologically, the spindle cell and the epithelioid cell, right? So I'm not going to go with details of the histopathological structure. You can look it up. You can look up this lecture again. Mitotic index classification is important, and on basis of mitotic index, you would be classifying it as benign or highly malignant, and that depends upon the number of mitosis seen, mitotic cells seen in a high power field. So less than 1 per high 50, over 50 high power fields. So you're visualizing 50 high power fields, and in one of them you find that there is mitosis positive. That is a benign gist. But in 10 high power fields, in all of them you find them to be having mitosis. All 10, it's highly malignant. So that is how the scale proceeds from benign to highly malignant. Metastasis usually bloodstream to liver and lungs, transperitoneal, and lymph node metastasis gist is not very common, less than 10%, as opposed to CRCs, where the lymph node metastasis is more than 50%. Size, diameter usually less than 2 centimeters. They are good prognosis. Low mitotic index, good prognosis. Tumor spillage not there while removal, good prognosis. Incomplete or complete resection would again determine the prognosis. Clinically, they are well demarcated, intramural. They are usually found inside the muscle mass. And then they go exophytic, because I told you the ICC cells are where? Inside the muscle. So it's usually an intramural mass, usually proceeds outside into the lumen, outside away from the lumen, but it can also proceed into the mucosa and the lumen, and there you will have a luminal obstruction. But by and large, GIST usually present as extraluminal growths. Only 70% are symptomatic. If the GIST is small, which is usually 30%, no symptoms at all. 70% larger tumor, you'll be having abdominal pain, hemorrhage, anemia, and you can be having a lump, right? The diagnosis by a CT scan, endoscopy, that basically means a colonoscopy, an MRI, you can do an angio, you can do a FNAC or a biopsy, radiology to differentiate it, like from leiomyosarcoma. Stomach differentiation is easily done by a variable of the stomach, but here you're talking about the colon, so forget that. But markers are important for GIST, and there are 3 markers which are usually, and the percentage is shown: the CD117, that is the KIT marker; the CD34, I just now told you, the 2 markers that I told you. I told you that these are Desmin CD34 positive and CD117 positive, right? The 2 markers there. And then, of course, the DOG1 is again a protein, the DOG1 marker, and that may aid in the diagnosis of GIST. So the 3 markers are usually found in the GIST tumors. The treatment is surgery primarily. Chemotherapy, I told you, tyrosine kinase inhibitors can be given, and these are usually indicated as adjuvant therapy, or they can be used for inoperable disease, or for metastatic disease, or even in advanced cancer, which are inoperable. So the survival in advanced cancer is almost 75 to 80% if you start using a KIT inhibitor. So see, this is a very good drug for GIST. It gives very good results, 40 to 70% response rate even in METs or inoperable disease, right? And if you have resistance to imatinib, for the second one, again TKI, and that is the sunitinib. So either of the 2 can be given. The rarer colorectal tumors, just 2 of them. Lymphoma, the primary lymphoma among all GI sites, most commonly in the cecum and terminal ileum, right? That's the most common site. Colorectal, only 10% of all GI lymphomas. Usually an isolated disease. The patient presents a cecal lump, rarely a colonic lump. Bleeding, obstruction, and pain is the presenting feature. If you have a secondary colonic lymphoma, then it is usually part of the generalized disease. If it is primary, it is a localized colonic carcinoma, localized colonic lymphoma. Treatment, resection, and anastomosis, or as a part of chemotherapy for lymphoma, if it is a secondary lymphoma, as a part of the generalized disease. So remember this: a primary colonic lymphoma, just like a primary gastric lymphoma, the treatment of choice is surgery, not chemotherapy. But a generalized lymphoma or a secondary lymphoma in the colon or stomach, the treatment is chemotherapy. Surgery is only second. Leiomyoma, leiosarcoma, the need to refer to this was in context to GIST, and this is more common in the upper GI, very commonly found in the colon, and it is distinct from a gist of the colon, right? Leiomyomas are more common, leiosarcoma is less common. If you have a sarcoma, leiomyosarcoma, it is commonest in the lower rectum, in the lower rectum, lower part of the rectum, and the DD between benign and malignant is very, very difficult. So they all have to be treated like, for example, they are a malignant leiomyoma or a leiomyosarcoma. Treat them as a leiomyosarcoma. And accidentally, usually asymptomatic lumps or accidentally discovered on a digital rectal examination or endoscopic examination. If you have a large lesion, then a lump would be there, bleeding can be there, obstruction can be there. Treatment is excision, and local recurrence is very, very common. The neuroendocrine tumors are the carcinoid tumors, and 25% of all GIs are in rectum. And I think we covered the carcinoids in earlier lectures. If not, we'll be covering them in the further lectures. So basically, if you have a well-differentiated neuroendocrine tumor, it is usually a carcinoid. That's also known as a carcinoid. Size less than 1 centimeter, more than 2 centimeters, 60% would be having mets. So a carcinoid can either be a benign carcinoid or it could be a disseminated carcinoid when we would having a dissemination. And the third term to be used with carcinoid is the carcinoid syndrome. So remember, whenever we talk about carcinoid, three terms to remember: a carcinoid disseminated or malignant carcinoid, and number three is carcinoid syndrome, which can be there even in a benign or a malignant carcinoid. Syndrome basically has to do with the secretion of the functioning part of the carcinoid cell, and the benign and malignant has to do with the spread of the disease, right? The treatment has to be dissection. If it is a poorly differentiated neuroendocrine tumor, then more radical surgery is required. In colonic neuroendocrine tumors, less common, more likely malignant, 2/3 have met. So see, where you're finding the neuroendocrine CRCs at a later stage, and they usually present as bulky tumors, and the treatment has to be more radical. I think that finishes the colorectal cancers this time. And next time, I think we're going to start with the rectum. We finished the colon this time. And this is just a repetition of what we said. And the YouTube Prime channel, you have to type in Rajiv Sinha JHS. I forgot to mention it here. I've slightly altered the name of my Prime channel. And you have to just type JHS along with my name. And you will be able to access all the lectures. And this would also be there either day after tomorrow or tomorrow. I'll be posting it on the website. Thank you for your time.